Let's continue with where we left off with the respiratory system, pulmonary system. Respiration, by the way, is everything that includes moving air in and out, getting it to the tissues, using it inside the mitochondria. I mean, the whole process is actually respiration. So ventilation is a more accurate description of what happens when you're just moving air in and out. And this is a big deal because if somebody comes to you because they can't breathe, they rarely say, oh, I think my mitochondria aren't working right. They say, hey, doc, I can't breathe. Okay, so ventilation is being able to move air both in and out with equal ease. Remember, we need the compliance of the lung to allow it to stretch. We need the elasticity to help pull it back. It needs to be in a perfect balance. The universal gas law looks, complicated. What it does is describe what happens if you change the volume, if you change the pressure, if you change the temperature of gases. We're not worried about temperature because our body keeps our temperature very stable. The change in volume is equal to these factors here, the quantity of gas molecules, a universal gas constant, and so forth. But what it really tells us is that pressure is inversely related to volume. That's the whole thing. If somebody says, well, the ideal gas law says, you'll say, oh, yeah, I know that. But for humans, all it really matters is that pressure and volume are inversely related. If I make the volume bigger, the pressure goes down. If I make the volume smaller, the pressure goes up. That's how we move air in and out of our lungs. We make the lungs bigger and it sucks air in, and then we make them smaller and it blows air out. It's actually that simple. So we're going to change our volume inside the lungs with our muscles. We pull our chest out or we push it back. We pull our diaphragm down or we push it back up with our ab muscles or whatever. And therefore we're changing the volume. We're making air go in. We change it again. We make the air go out. Now, atmospheric pressure is 760 millimeters of mercury. So it will push, a barometer for 1 atmosphere of pressure. It pushes it up 760 millimeters in a tube. And so that's 1 atmosphere. That's at sea level. If you go up high where there's not as much air, the pressure drops. We'll discuss that later. But right now we're just saying, okay, we live in the atmosphere. What's outside here is 1 atmosphere of pressure. Now, if our airways are open, if my mouth is open and the air can go wherever it wants, the pressure is the same inside as it is out. It equilibrates and no air is moving because the pressure in the lungs is the same side as out. So instead of saying, well, we have 760 out here, and if we make 762 in here, then there are 2 different all you do is say, if there's no difference, the airway pressure or the alveolar and out airway opening pressure are the same, we say 0. That way, if there's a little bit more, you can have 1 more centimeter of water, millimeter of mercury, or 1 less. If it's more inside, you blow air out. When the pressure's higher, it pushes air out. When it's lower than the outside, you pull it in. So if I change it by a couple of centimeters of water, I'm going to blow out some air. I'm going to suck it back in. And that's what we're doing. Remember, in a normal lung, if you change it 1 centimeter of water, pressure will move about 200 milliliters of air, one way or the other, whichever way you changed it. So that's typical. If I add 5 centimeters of water pressure to the lungs by squashing them, about 1 liter of air will move out, about 1,000 milliliters of air. And so since I'm a normal breath is about half a liter. Okay, if I change it by 2.5 centimeters of water, I suck the air in, I change it the other direction, it blows it back out again. That's what I'm doing to move the air in and out. So here we have our breathing muscles. Our diaphragm is pushed up like this in its normal configuration. When I contract it, it flattens. It pulls down. And it stretches the lungs and makes them bigger. That drops the pressure and sucks air in. I also can use my chest wall muscles to pull outward and pull inward to make the lungs bigger so air comes in, make them smaller so air goes back out again. So I'm changing the volume of the lungs with these muscles, and as a result, it's changing the pressure and makes the air go in and out. Great. Here's how the diaphragm works. When it flattens, it pulls down, stretches the lungs, make them bigger. Inhalation, exhalation. Now, the more scientific term for this, instead of inhalation and exhalation, is inspiration and expiration. Inspired gas is what you suck in. Expired oxygen, measuring expired oxygen. Now, inspiration is not what I give you on a daily basis with my magnificent lectures, but instead it means sucking air in. Okay? To inspire, I'm going to contract the diaphragm to pull down on the lungs, and the external intercostals are going to pull out. Muscles can only pull, so the ones on the outside pull out, the ones on the inside pull in. Okay? If you pull them out, you make the lungs bigger, air is going to go in. You pull them back in, the air goes back out again. Now you can also use some of these shoulder elevator muscles. If you're breathing really hard, you're exercising, you see people do that, okay? Well, that's stretching the lungs from the top. Those aren't primary muscles of inspiration, but they're used when you have to breathe real hard. If you have lung disease and you have a hard time getting enough air, you'll see people really working and their shoulders are going up and down. But mainly it's the diaphragm, especially at rest, and the external intercostals, especially as you become more active. Expiration at rest is passive. When you open your lungs, you're pulling on those rubber bands, and when you relax, the recoil pulls it back. So inspiration requires a tiny bit of muscle effort, but expiration is totally passive. It just lets the air go back out again so they return to their original size. So stretch the rubber bands to breathe in, let them recoil to breathe out. During exercise, you need more push and pull than you can get by just that. So when you breathe in more deeply and then you got to get the air out faster, you use internal intercostals to pull the lungs back small again, and your abs shove the diaphragm back up into its original place. All of those things compress the lungs and air goes back. So at rest, you can hardly see the person's chest move. Sometimes you got to put your face next to their nose to see if air is moving, because they're just using their diaphragm almost completely. Suck a little air in and then relax it. You can see their chest rise and fall just barely. Those are external intercostals pulling out and then just relaxing. During exercise, though, it's real easy to see people breathe because they're using all of these muscles to pull bigger and push harder. Now here's the pressure volume curve, and you'll have to probably do something like this on the test. This is, it shows what happens, inspiration, if I drop that pleural pressure, that negative pressure outside the lungs. If I stretch, what I'm doing is dropping the pressure in the pleural space, and it sucks the lung along with it, causes the lung to get bigger, and air goes in. So you pull on that pleural space, the numbers are getting smaller and smaller because it's getting a more and more negative pressure to pull, and air goes in. And then when you relax, it goes back out. because of the way the tissue is designed, it doesn't go straight up and down like it was in a plastic tube. Instead, there's a little give, and then the air comes in. There's a little give, and then the air goes back out. But the main thing is the angle of this slope. You know, if when you change a tiny bit, you get a whole lot of air, that means you have a really compliant lung. 1 centimeter of water gives you half a liter. You know, like if this thing was pointed all the way up here, 1 centimeter of pressure change gives you half a liter of air. That would be an overly compliant lung. 1 centimeter of water, you know, should give you a couple hundred milliliters of air. Okay? And so if a steeper slope means the lung is overly compliant. If the slope is too flat, it means you have too much elasticity, not enough compliance. And these are two different kinds of airway disease. If it takes a ton of pressure to get any air to go in, then this slope is way down here. I changed 2 centimeters of water of pressure and I only got this much air. That's not very good. I'm going to have to suck harder and harder and harder just to get enough air to stay alive. Now, the work of breathing is normally very little. You know, you have to stretch those rubber bands just barely, you know, and then they pull back on their own to get you to breathe out. There's some tissue resistance in actually having to move the lung tissue. That airway resistance, just the air going through all the tubes, it's very low at rest, you know, especially down at the alveoli. We talked about that. And so what you have to do is overcome these various things to get the air to go in and then to get it go back out again. Now, these are all so low that there's very little work done at rest in a healthy lung. But if you're exercising as hard as you can, you're moving those tissues faster, you're trying to blow the air through the tubes, and it can barely go through that fast. And all of these resistances to air movement get higher and higher until it becomes not worth breathing faster because you're using more energy than you're getting from the extra air. It becomes limiting if you're already breathing as hard as is worth breathing. You can always breathe faster if you want to, but you're not getting enough more air to make up for all the extra work you're doing. So that becomes a limitation to exercise, perhaps. Also, if you get sick, you might, if the airway's all squeezed shut, then your airway resistance goes way up. And then suddenly, you have an asthma attack. And that's an airway resistance problem. Normally, you're sitting still, not doing anything else. Only about 3 or 4% of your energy that you're spending is breathing. Well, that's pretty low, considering that's about all you're doing. Your heart's beating and your lungs are moving. And yet, most of the energy at rest is your sodium-potassium pumps moving ions around in your body where they're supposed to go. There's very little energy actually expended at rest by moving your air in and out. During exercise, it can go up so high that it becomes not worth breathing harder because you're using so much energy to breathe that it's not worth breathing any harder. Usually it's not the lung volumes that limit a person's ability to exercise, but how efficiently they can move the air in and out up to their maximal exercise level. All right, and so what we're going to do is change our lung volumes. You got to make the volume bigger so air goes in. You make the volume smaller so air goes out. These are volumes you have to memorize. You got to learn these because you'll use these in every hospital setting, every clinical setting there is. You'll be talking about, well, this person's vital capacity is such and such, and their total lung capacity is such and such, and their residual volume has gone way up because, they have this kind of disease. And so you need to know what these are. The tidal volume is what you're breathing right now, okay? And your resting tidal volume is about half a liter. Now, it's bigger for me. I'm 6'1", than it is for somebody who's 5'4", okay? But it's kind of the average is about half a liter. You suck it in and you blow it out. It's the same air, so it only counts once. You suck in half a liter and then it goes back out again. That is your tidal volume, that half liter that goes in and out and in and out. During exercise, it gets bigger because I breathe deeper, okay? Anytime that I breathe in, though, I can always, with additional effort, I could breathe in more if I wanted to. So at the end of a normal inspiration, I can go and suck in more air. That's my inspired reserve, or my inspiratory reserve volume. So I'm using this, but I could do this. This is a reserve that I have available to me. And every time I blow out my normal breath, I could blow out more with some additional effort. So there's another volume of air below my tidal volume that I could blow out more. So if I wanted to work really hard, I could go and move this amount of air in and out of my lungs. That total amount that I can move if I try really hard is my vital capacity. And it just is the amount I'm breathing now plus how much more I could suck in and how much more I could blow out. These are the amounts that I actually have access to. And those added together give me my vital capacity. It's tidal volume plus inspired and expired reserves. Vital capacity is the one that's most often tested. And I'll do a demonstration lab, which we normally would do together, but I'll do it for you, and I'll show you how you measure it with a spirometer. You see how much you can suck in, how much you can blow out. You measure your vital capacity, and is that okay for a guy my size, or do I have some lung problem? Now, when you've blown all the air out you can, there's still air in your lungs. Your lungs don't collapse. Your chest wall doesn't, you don't break all your ribs and collapse everything. So there's still close to a liter of air in your lungs when I've blown out every bit that I can. That is called your residual volume. It's the residue. It's the residual volume, the amount that's in your lungs after you've blown out all you can. So here I'm breathing this much. I'm sucking in this much more, blowing out this much more. So I have my tidal volume, my inspired reserve, my expired reserve. That makes up my vital capacity. And then I have the air that's left in my lungs after I've blown out all that I can, but it is still air that's in there. So that is included in my total lung capacity. Total lung capacity is the total amount of air your lungs can hold, which is your vital capacity plus the residual volume. So, residual volume. So, vital capacity is those three volumes you can use. Total lung capacity is the vital capacity plus that extra air that's left in there after you've done blowing out. So the total your air your lungs can hold. And for the average person, that's around 4 to 6 liters. Less if you're a small person, more if you're a big person. Now the forced vital capacity, these are measurements. These are, you do an FVC test, forced vital capacity test. And the forced vital capacity test, you suck in as deep as you can, you put a sensor in your mouth, and then you blow and blow and blow and blow and blow until all your air is gone that you can. And that is a test of your vital capacity that has been forced to get every bit of it. So your FVC is a very common number that's used in clinical situation. Your FVC is your vital capacity. It's just the test where you forced every bit of vital capacity you could get. Your FVC is your forced vital capacity. Your FEV1 is the forced expired volume in 1 second. This tells you how clear your lungs are. Because if I can blow out 5 liters, but it takes me 5 minutes to blow it out, then my lungs are not working very well. What you want is most of the air to go out in the first second. So you suck in, and then you blow, and the first second, 80% of your air should come out. If it doesn't, you have a little bit of blockage, or a lot of blockage, depending on what your forced vital capacity turns out to be. Mine is 80% or better under normal conditions. During allergy season, it might be 70%, because my airways are kind of swollen shut, and I don't get as much air out. My wife has had pneumonia a couple of times and has had some damage to her airways, and her FEV1 can be 60%. That's pretty low. I mean, that's not as good as you would like. When you blow really hard and the air doesn't come out very well, it's an indication of some damage or some swelling or some allergies or you've been smoking too long or something. And therefore, your FEV1 should be 80% of your FVC. So what if I were to blow out 5 liters? What should my FEV1 be? 4 liters, because 4 is 80% of 5. Okay? Your functional residual capacity is how much air is in your lungs when you just relax. Okay? When you have emphysema or something and you have an overly large residual volume because all of your airways are damaged and stretched out and stuff, your FRC will go up. And so even when you've breathed out normally, you have too much stale air in your lungs. Remember, you got to blow it in and out for it to do any good. It doesn't do any good if it just sits in there. It becomes stale. So if your functional residual capacity is too high, it means that at the end of normal respirations, you're not getting enough air out. And it's too big. You probably have some kind of lung disease. So here's the graph. Here we have, I'm breathing in and out about half a liter. Okay, this is the total this is my, functional residual capacity here. At the end of my last exhalation, I had my residual volume and my reserve volume and a residual volume. I got some air in my lungs. I'm sucking in about half a liter and then blowing it out again, in and out. So this is my tidal volume here. And I wish they would just say tidal volume, but they say volume sub T, which is tidal volume. So here's my tidal volume. Now, if at the end of this breath I suck in as deep as I can get my inspired reserve. And then at the end of here, I blow out as hard as I can. That's my expired reserve. So here is my vital capacity. Okay? Again, from the top of what I can suck in to the bottom of what I can blow out, that's my vital capacity. That's the amount I can use. My total lung capacity then is going to include my residual volume. So this whole thing is total lung capacity, but the amount I'm able to move on the needle on the chart is my vital capacity. Okay, so we are moving air in and out. Let's say we're moving in half a liter, moving it out half a liter at rest. So my tidal volume is half a liter. And let's say I'm breathing 20 times a minute. Now, average breath rate for humans is somewhere between 12 and 20 at rest. And so if I'm breathing in half a liter per breath, and I breathe in 20 times a minute, what is my minute ventilation or pulmonary ventilation? It's 10 liters per minute. Okay? Half a liter times 20 is 10 liters. Okay? It's, if I am going down a field picking strawberries and I pick, 5 buckets per minute, and each one has a gallon of strawberries in it, how many gallons did I get per minute? I got 5 gallons of strawberries. It's the size of your breath times how many you took. Okay, so in this case, your minute ventilation or pulmonary ventilation would be 10 liters per minute. Now, during exercise, I take bigger breaths and I breathe faster. Okay, well, how about if I was breathing 2 liters every breath and 45 times a minute? Well, I'm moving 2 times 45 is 90 liters per minute. The size times the rate. It's like heart rate. Stroke volume times heart rate gives you cardiac output. Okay, so here we have 2 liters per minute. So you can see how it could go way up during exercise, which is, of course, what you want. Now, not all the air that you suck in your mouth makes it into your lungs, because your tubes are this long, and then they're this long, and then they're little tubes, and finally it makes it to the alveoli. So when you suck in air, part of the air stops in the tubes before it ever makes it into the lungs, into the alveoli. That's called your dead space, or your anatomic dead space. It's just the amount of normal anatomy that will take up some of that air you breathed in and not quite deliver it. If I breathe deeper, it would go in, but with every breath, when you stop, whatever was left in the tubes is your anatomic dead space. So if I measure that I breathed in a liter of air at my mouth, but my dead space is a quarter of a liter, then only 3/4 of a liter made it into the alveoli. And that's the air that matters, because it doesn't do anything unless it's in the alveoli. So it is your tidal volume minus the alveolar air will give you your anatomic dead space. Okay? Because it's the difference between how much you breathed in and how much made it into your alveoli. The rest of it got stuck in your airways, right? Anatomic dead space. So alveolar ventilation, which is what really matters, the ventilation of the alveoli, or the ventilation of alveoli, large A is alveoli, small a is going to be arteries, okay? But the alveolar ventilation is the amount that actually makes it into the alveoli each minute. Okay, well, I breathe in a liter of air. Only 3/4 of it makes it into the alveoli. So every breath, I have 3/4. That times how many breaths I took would give me my alveolar ventilation. All of the air times my breath rate gives me my pulmonary ventilation. But you got to subtract the dead space every breath to find out how actually much made it into the alveoli. So let's go back to our previous example. We were breathing in half a liter, 500 mLs. So we were getting 10 liters of air moving in and out of our mouth. Half a liter times 20 breaths gave us 10 liters of pulmonary ventilation. But let's say our dead space is 150 mLs, which is about average for human beings. Well, then the pulmonary ventilation is 10 liters. It's half a liter times 20. But alveolar ventilation is that breath size minus that dead space that it didn't make it in times 20. Because 20 times I sucked in half a liter, but only 350 of it actually made it all the way to the alveoli. So it's simply the tidal volume minus the dead space times your breath rate. So 7 liters made it into the alveoli each minute, even though 10 liters were going in and out of your mouth. The rest of it never made it out of the dead space. So a deep breath is more efficient than a shallow one, because every breath you lose the dead space, it never changes. It's the same size every time. So if I take a bunch of whole little tiny breaths, every breath I'm losing that 150 mLs, okay? But if I take a really deep breath, let's say I sucked in 2 liters of air, I only lost 150 mLs still. So I got a bigger bang for my buck. So nice, big, slow breaths are more efficient for ventilating your lungs than taking a bunch of little dinky breaths. What would be the alveolar ventilation if your patient was taking 150 ml size breaths? 0. Because it'd be just moving it in and out of the dead space. You'd never suck deep enough to get it to go into the lungs. So really small breaths, most of the air is dead space, and therefore you're not ventilating very well. Now here's another wrinkle, and this will show up on the test. The actual dead space is not exactly 150 mLs in everybody. I'm a big guy, so I have bigger lungs. So my tubes are bigger. My dead space is more than 150. If you're 5'2" and 115 pounds, you have a much smaller dead space than I do. So if you want to be more accurate, it's still a guess, but it's a lot better guess than giving everybody the same size. You say that your dead space is approximately 1 milliliter of air for every pound of body weight. And this is like if you have a relatively normal body weight. If I put on 50 pounds, my dead space wouldn't get bigger. But, let's say you're kind of normal size. If you weigh 100 pounds, your dead space is more like 100 mLs. I weigh 195, so I probably have a dead space of 195 mLs. It's not 150, it's bigger than that, okay? So if on the test you see a 140-year-old female subject has such a data, I think, aha, he's going to ask me a question that involves dead space, because if she's 140 pounds, her dead space should be 140 mLs. What if it's way more than that? Then she's got a problem, okay? So let's look at this practice question. A 60-year-old male, 170 pounds, moderate dyspnea with moderate activity, means he has a little bit of breathing difficulty when he's exercising modestly. Spirometry is indicating that his tidal volume is 600 mLs per breath. A little bit bigger than the 5 that is typical, but you go with what you measured. Blood calculations, you can measure what the alveolar ventilation is, right? You can measure the alveolar ventilation by doing some blood gas work. And, if we were in medical physiology, you would learn to do that, and you will if you go to the hospital and have to do it, or you'll have a machine that measures it for you. But here we are, we have a tidal volume of 600 mLs per breath, and we know that 360 is making it into the alveoli. Well, what's the dead space then? Well, 600 minus 360 is 240. Okay? It's the difference. This went in the mouth, this made it to the alveoli, the rest of it got stuck in the airways. Dead space is 240. Is that right for this person? No, it should be 170. Remember, that's why I said, man, if you see a respiratory question and it has the person's body weight in it, aha, the dead space is supposed to be 170. Let's see what it turned out to be when I measured it. Oh, it's too big. So this person's got swollen airways or overexpanded airways or something. There's too much dead air getting lost in the lungs and not making it to the alveoli. That's a bad thing. Now, if it were 180 or 190 or 150 or 160, it'd be okay. I mean, approximately 170 is fine. But it shouldn't be 240. It shouldn't be 300. The dead space should be approximately a pound of ml per pound of body weight. So in this case, You calculated it to be 240. You know what it should be, and therefore 240 is too big. Person has lung problems. Another measurement that will come from your breath test is your peak expiratory flow. In other words, how fast can that air move through the airways? It's another good indication of how healthy the airways are. Unhealthy airways have a tendency to get soft and collapse when you try to blow out. And you go, and the air doesn't move out like it's supposed to. So when you blow out hard, the faster the air can move through those tubes, the healthier the airways are. And this is called the peak expiratory flow, or PEF. Typical flow rates of the maximal rate of 5 to 8 liters per second, or 300 to 500 liters per minute, depending on whether you're using liters per second or liters per minute. And when I do the demonstration lab, that's one number that we'll be looking at to see if my peak expiratory flow is about what it should be. It should be somewhere in this range. It doesn't really matter if it's a little bit higher, that means your airways are even clearer. But these are normal expiratory rates for a healthy lung. And if the air doesn't come out as well as it should, if your peak expiratory rate is slow, or your FEV1 is too small, meaning the first second not very much air came out, what you're experiencing is called airway closure. Airway closure always happens when you blow so hard that your air stops moving out of the lungs. You keep pushing and pushing, and you collapse those little tiny soft bronchioles, and no more air moves. What you don't want is for it to collapse halfway through the breath. If you have lung disease and the airways are too stretched out and gooky and soft and floppy, as soon as you start blowing out, they collapse, you suffer airway closure, and you can't get the air to go out. So you go, you can't get the air to go out. And that's what happens to people with emphysema. So here we have, when the lung volume is high, the airways are really, lung volume, is high. The resistance to flow is really low. As you blow out the air and the lung volume gets smaller and smaller and smaller and smaller, the resistance goes up and up and up. Try it yourself. Take a deep breath. When you first blow out, it's real easy. Blow out most of your air and then try to blow out more. It's a lot more resistance because you're smashing the airways shut, which happens normally when your air is gone, but shouldn't happen early and cause you distress and difficulty breathing out. So here is the curve that you will see on your pulmonary test, and this shows how fast the air is moving during an expiration and an inspiration. I'm blowing out my air, and now I'm sucking it back in. How fast from zero? It's flowing fast here. It's flowing fast now. It's going in one direction, going in the other direction. But the farther you are from zero, the faster the air is moving. So I take a big deep breath, and then I blow really hard. And at first, the air comes out really fast. That's my peak expiratory flow. Then, as the airways start to compress, it gets slower and slower and slower and slower and slower until no matter how hard I blow, I can't get any more air to go out because I've basically smashed the airways shut at the end of that expiration. Then I start sucking it back in again, and it pulls those airways open, and it keeps them open until my lungs fill up. There's not resistance here. You just can't stretch them any farther. So it's going to stay wide open while you're pulling the airways open. But during expiration, which is important here, this is what you're testing. You're testing expiratory flow, and it's called effort independent. You get down here, you can't get it to go any faster by blowing harder. It's effort independent. Blow even twice as hard. It won't go out any faster because all you do is smash the airways harder. Okay? Suck it in, blow it out. So this is the area right here where the compression of the airways is reducing the velocity of your airflow coming out. Peak expiratory flow right at the beginning is the fastest point. And you're only there for an instant. Here we have the equal pressure point. If you are blowing air out and the air pressure in here is high enough to keep the airways open, then up here where the compression might collapse the airways, you have cartilage rings holding them open, so you can keep blowing out for a while. But if your damaged airways allow them to collapse too soon, then almost as soon as you start blowing, the pressure out here is higher than it is in here, and their airways collapse, and nothing can go out. So you want the equal pressure point to be as far up the respiratory tree as possible. You don't want the equal pressure point to be down here close to the alveoli where your soft airways can collapse. So now let's look at how the different types of lung disease will affect our ability to move air in and out. Well, you have a couple of main kinds of lung disease. You have obstructive and restrictive or constrictive lung disease. Obstructive is COPD, chronic obstructive pulmonary disease, COPD. Comes in type 1 and type 2. Type 1 is emphysema. Type 2 is chronic bronchitis. Those are both obstructive diseases. That means your airways become obstructed when you try to blow out and you can't get air to go out. This is what I've talked about. The equal pressure point's too close to the alveoli, you're pushing too hard, you're smashing your airways, and you can't get the air to go out. So you wind up with a lot of extra air, stale air, hanging out in your lungs at the end of every exhalation. Hard to exhale, emphysema and chronic bronchitis. Restrictive or constrictive lung disease, fibrosis or tuberculosis, you add a lot of connective tissue in there, fibrous connective tissue, and the rubber bands get too strong. You can't inhale. You have too much elasticity, not enough compliance. Up here you have too much compliance. Your lungs are so easy to open because everything is rotting away with emphysema. The rubber bands all break. The sides of the airways lose their elastic fibers. They get all gooey and floppy. It's real easy to breathe in, but when you try to breathe out, they collapse. You can't breathe out. Too much lung compliance up here. Whereas down here, you have too much elasticity. Fibrosis, just think of adding a whole bunch of extra stringy fibers in there, and you can't breathe in. Pulmonary emphysema. It often comes with chronic bronchitis, but type A or type 1 COPD, the lung compliance is increased. You lose your elasticity because so much of the tissue is melted away basically by the disease. Residual volume increases. In other words, you can't blow the air out, so you get more and more at the end of a breath. You've still got a lot of stale air in there. Vital capacity gets really crappy. No matter how hard you try, you can't get very much air to move. It becomes difficult to exhale. You can't blow out because the airways collapse. Peak expiratory flow, FEV1, are decreased. You can't get the air to go out. Overdevelopment of supplemental muscles. People get ropes going from their shoulders to their neck because they're always trying so hard to suck in more air because they can't blow out anymore. They got to move air somehow. Pursed lip breathing. You will see them doing this, and they're unfortunately get the nickname of the pink puffers. Their faces kind of pink up because they're working so hard, and they're managing to get enough air, but only by... That's called pursed lip breathing. When you breathe out, you're adding resistance, which helps keep the airways open. You're putting a little extra pressure in the airways to keep them open so air can move. Same thing with continuous positive airway pressure. These CPAP machines that people use for sleep apnea and stuff, you can use them for emphysema too. It puts a little air pressure in the airways and keeps them open so you can move air. They don't collapse so easily. And at some point, they will try to remove the worst part of the lung, reconnect some of the rubber bands so that you have a little bit of help breathing out again. Emphysema, overexpanded lungs, too much compliance, can't breathe out. The pink puffers and blue bloaters. Pink puffers, pulmonary emphysema. The blue bloater, chronic bronchitis. This person is developed such damage to the airways that they're leaking so much mucus and it just blocks the airways. Now, it doesn't help to puff because opening the airway that's blocked with a mucus plug doesn't help very much. So they lose their ability to oxygenate and they start turning blue. Their face also kind of and neck sort of bloats because the pressure in their lungs causes the blood to back up in their jugular veins and thus in their head and face. Okay, chronic bronchitis. The airways are blocked with mucus plugs. Emphysema, the airways are just all loose and floppy from damage over the years, and a lot of times these go hand in hand as just COPD. Whereas restrictive lung disease, which is less common, but it happens, some people get fibrosis of the lung, idiopathic. No reason for it. We don't know why. Some people get it because they breathed bad stuff their whole lives, because they smoke inhalation, breathing in toxic fumes from a chloride spill or something, and it damages their lungs. They create a lot of scar tissue. The fibrosis causes it to become hard to inhale. Very elastic. Low compliance. Low compliance means they can't breathe in. Tuberculosis will do it too. Tuberculosis is a bacterial infection, and your body responds by building fibrous balls around the areas that are infected to try to keep you alive. It's a defensive mechanism, and it works for a little while, but not forever. After a while, your lungs fill up with these fibrous balls, and you have too much restriction, and you can't breathe in, and you can die from that. Fortunately, tuberculosis nowadays is treatable. It wasn't before we had antibiotics. Here are some pressure curves. There's a normal one. You blow out. This is the top half of that one. You suck in here. You blow out there. There's your peak expiratory flow way up there. Remember I said 300 to 600 or 400 to 600 liters per minute, is a normal peak expiratory flow. So you blow. It goes out really fast. You get most of your air out before you can't breathe anymore. Now, if I have obstructive lung disease, it's easy to breathe in, but really hard to blow it out. So it takes forever to get the air out, and I don't get very much air out. I still have an awful lot of air in my lungs when I have to stop because my airways collapsed. So it's going to be lower. You're not moving as much air, but you have more air in your lungs, and you can't blow it out, so you have more air in your lungs when you finish, too. Whereas restrictive lung disease, you can't open your lungs, so your total lung capacity is small. I can't breathe in very much. It's easy enough to breathe out, but I don't have very much air to breathe. Okay? If I can't breathe in much, I can't breathe out much. So in both cases, they're going to be low, but in one of them I have a lot of air left at the end of my breath, and the other one I don't. This is obstructive lung disease, COPD, and here's restrictive lung disease, tuberculosis, or fibrosis. And asthma is it's considered an obstructive disease because it's harder to breathe out than it is to breathe in, but it's not exactly the same as the others. With asthma, it's hard to both breathe in and out. Asthma is a reaction to an allergen or to cold or to dry or to nothing. I mean, it can be like an autoimmune thing almost, where your bronchioles swell shut. And so it's hard to get air to go in and out. It's hard to breathe in. It's hard to breathe out. It's more harder to breathe out than it is more harder to breathe in because the airways are already mostly closed. So if you push hard enough, you collapse them some. But it is considered an obstructive disease. A lot of people will get asthma along with COPD because they have so much going in there. They also have reactions of the airways that try to swell them shut. So here, if I am moving X amount of air, where's my cursor? If it takes this much pressure to get the air to come in and that much pressure to make it to go out, with asthma, it's going to take a bigger pressure change to get the air to go in and a bigger pressure change to make it go out. A larger change in pressure to get the same volume. This is the breath volume. I'm just trying to get in my half liter, but it's taking more work to suck it in and more work to blow it out with asthma. And that's it. That's a lot. That's plenty for ventilation.